Hello, my friend. Welcome to my show Chronicles of a Learner RN, and thank you for listening. My name is Ritika. I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Before I talk about what we'll be talking about today, I just want to say welcome to Season 2. I didn't really have a season finale for the last season, but I took a bit of a break, went on a holiday, started semester 2 of my studies, and I just didn't really have the time to keep going with this show. But at the moment I can, come back to it, talk to you guys a little bit, tell you what's up, share some new things. I think my sort of style of podcasts sort of morphed into less about my experiences and more about teaching, which isn't necessarily a bad thing, but I think I want to really focus on going back to the reflection part of things. I don't think I'm really qualified to be a all-around educator on these topics. I can just really speak for what I've learnt and how I look at things. So that being said, today we'll be talking about triage. Triage is something I've only started really recently, within probably the last 2-3 weeks. So I'm a very, very, very baby triage nurse, not experienced at all. And today we're just going to talk about what I've learnt doing triage for these last 2-3 weeks. So in Australia, we've got, I think it was Melbourne. I think it was Box Hill Hospital back in the 80s or 70s, or I can't remember when, a really long time ago, was actually the first metropolitan hospital to come up with at the time it was the 3-tier category system to prioritize sick people, essentially. Category 1 means you need help like right this second. Category 2 means it's serious, but it's not life-threatening, or not yet anyway. And category 3 was people that could wait, pretty much. It may need to be urgent, but it's not an emergency. This then has morphed into the Australasian triage scale, or the ATS. Yeah, ATS. So we've moved from a 3-category triage scale to a 5 triage category scale. I don't think that sentence made sense, but you get what I mean. Basically, saying 1 is you need treatment and assessment at the same time, like right now. 2 means you need urgent assessment, urgent treatment, but you can wait 10 minutes. Category 3 is you do need urgent assessment and treatment, but you can probably wait about 30 minutes. Category 4 is when it starts to get less urgent and you can probably leave waiting for an hour. Category 5 is pretty much not urgent at all, and the patient is able to wait about 2 hours. Now, these time frames, we should be adhering to these time frames, but unfortunately, with the way the hospital is overrun at the moment, for example, like Cat 3s are supposed to be seen within 30 minutes. Some people wait 3-4 hours before they get seen. Doesn't mean we can't start treatment, but it means their wait to see a doctor is quite significant. But every day we work to try and fix these issues, try and get people seen in an appropriate manner. And we'll talk about re-triaging in a second. If somebody deteriorates while waiting, we can always change the triage. So let's explain the triage process. So say you're walking into ED and you sit at the nurse's desk. I'm the nurse. I go, hello, are you here to see a doctor today? You say yes. Then I'll grab your information, try and get you on our system. Sometimes people haven't actually been to a hospital before, so you have to sort of add them as a new person, but otherwise you just sort of click the person that comes up and you do what's called add an encounter, which creates a new little, a file. I don't really know how it works actually. I just press the buttons and it shows up, to be honest. So then we get into the story. What's brought you into hospital? You tell me. I take all the pertinent information. So say you've had 3 hours of crushing chest pain, you can't breathe properly, and it's really uncomfortable, and it goes through to your back. And I look at you sitting here in front of me. You look sweaty, you look pale, you look really uncomfortable. Those are all big red flags in my mind. So I quickly write down 3 hours crushing chest pain, shortness of breath, and then I would write down how I see you. So pale, clammy, diaphoretic, looks uncomfortable. I'd do a blood pressure, probably on both arms, to be honest. Do your oxygen, have a listen to your chest, feel your pulses very quickly. Get a history if you've ever had cardiac history. We'd write that down, and then you'd be pretty much automatically be given a CAT 2. So you should be seen within 10 minutes, but usually chest pains, we get them sorted first and we get them going pretty quickly because they can change quite an instant. In this case, there's this book called the Emergency Triage something kit. We call it the ETEK, E-T-E-K. I can't remember what the second E stands for, but it gives us sort of a guideline for how to triage people. And cardiac sounding chest pain is an automatic CAT 2. So you'll find if you come in with chest pain, you'll be seen quite quickly because 9 times out of 10, it's a false alarm, but you don't want to be dilly-dallying if it isn't. So we treat all chest pain as cardiac chest pain, unless it sounds really obviously not cardiac. So in this case, my first thought would be an aortic dissection in which your aorta has split and is bleeding everywhere and is very, very time critical. Like we need to get you sorted ASAP if that's what's happening. So CAT 2 it is. We'll probably get you shipped to resus and get you sorted from there. So triage nursing is so different to everyday nursing. At triage, I have probably about 30-35 patients. So my ratio is 1 or 2 to 35-40 patients at one time. That is markedly different to the 1 to 3 or even the 1 to 1 I have in resus. And it's because of this that we need a waiting room nurse, which is the bread and butter of triage, to be honest. But it also means that I can't physically and sort of critically hold the information of every case that comes in. Like, it sounds a little insensitive to say this, but it goes in one ear, I type it out, and it goes out the other ear when the next person sits down. Unless it is seriously serious and I need to get that person seen immediately, I tend to sort of put to the back of my mind this person's case. And I'm sure this will get better with time because I'm still quite new, still have a little trouble compartmentalizing all these different cases, except for the ones that look really, really serious. So my first 3 days in triage were 1-to-1 with an educator, so they would be really close by. If I had any questions, I could just ask them right there. And first day was quite a culture shock. You get told so much information, you just don't know what's relevant. You don't know how to write it appropriately. I think the first day a lady came in with arm pain, thought she had broken her arm, and I wrote everything down, and then one of the doctors came up to me and told me, probably need to fix your wording because it looks like that bone has come out of their head and they've poked it back in, and it turns out I actually forgot to write that the issue was the arm. I wrote everything else except for the arm. So that was a big wake-up call to tell me I should really write down which limb is the affected limb. But I've also found that people, in their rush to come be seen in emergency, and it's no fault to them, not everybody knows how triage works. They come, they sit down, and they start telling me their life story with no hi, no hello, no name. They just tell me, I had a surgery this long ago and I can't poop. And I'm like, okay, we'll get to that. Just tell me your details first. Most people I've triaged have been quite pleasant. They sort of understand the pressure we're under. And I find that, actually, this was a tip one of my educators gave me, that once the triage is over, sort of give them a broad plan of what's going to happen. So if they've come in with infective symptoms and I've ordered some blood tests, tell them, go give your details, then someone will pull you through, do some blood tests, put in a drip, and then we'll get you sorted. Or if they've come in with foot pain or wrist pain or they think it's broken, tell them, go give your details, I'll order an x-ray, we'll get it imaged and we'll give you pain relief and we'll go from there. Or mental health patients, tell them that psych triage works separately to ED. We have no control or knowledge of their patient list that they need to see. So we can call them and figure out how long the wait's going to be, but unfortunately ED has no sort of no control over it. And I find if you just give people a little bit of peace of mind, a little bit of knowledge on what's going to happen, when it's going to happen, even if it's not sort of right now, if they get a sort of idea that it is happening, but it may happen in a few hours, they're more likely to understand and are less likely to come up every 5 minutes to the desk and go, what's happening? When am I going to be seen? I've been here too long. When am I going to be seen? Of course, this doesn't work on everybody. Some people, if you think about it this way, everyone's having their own emergency, which is why they've come to emergency. However, we as triage nurses need to sieve and sort through all of these people's personal emergencies to find out which emergencies are life-threatening. I think I had a lady come in who, I'm not too sure, she really wanted an enema. I think she might have been a bit constipated. But after her, and to be fair, the department was pretty clear. Like, she shouldn't have been waiting too long. She was only here for like 40 minutes. And in that time, we had someone come in with chest pain, which now you already know is an immediate Cat 2, and a child with broken radius and ulnar, so a broken bone that will need reduction. We pulled them both through to get them sorted, and this lady has come back going, I really, really need to be seen. How come these people came in after me but went in before me? And that's a great opportunity to educate on the prioritizing in emergency. So we go, this person could be having a heart attack and that kid has broken his arm. So they need to be seen before your sort of own emergency. And she was willing to wait after that, which is really nice of her. But yeah, the first 3 days were 1-to-1, so didn't really have to go far for advice, and I really took that opportunity to get as much advice as possible, because a lot of people come in with complex issues. So they'll come in with general lethargy, general weakness, but they've got infective symptoms, but their leg has been hurting for a few days, and it could all be related. And the problem with triage is you have a very fixed number of characters you can write your full triage in. So you really have to sort out what is the most pertinent information. And sometimes it's quite hard to sort of figure out which bit, sometimes when they're all low sort of emergency, they just can't stand it anymore and they can't get in to see their GP, you sort of struggle to pick which one is the one that needs to be sort of emphasized in the triage. And giving an appropriate triage score to all of these elements combined is sometimes quite difficult. But it was nice that I had an educator nearby to ask these questions because they have really good advice. So the second stage to my independence in triage was having educators close by. So they were on the shift, but they weren't with me. So I could just call them and ask for some advice. In this time, I sort of came into my own and started trusting my own judgment when hearing people's cases and figuring out what triage category to use. In this time, I'm still using the triage kit. Like, I haven't stopped using it even now because some cases are cut and dry, like chest pain, sepsis, ODs. They're all very easy to triage because you know which one it's going to be just from the presentation. But it's the more complex ones that I still need to use the triage scale for, because you can look at it one of two ways. You could do a primary assessment, and if they sort of meet that category, you can choose that category. Or in the appendix, there's sort of conditions that align with each category. So you can choose either one based on what they've come in with. But that doesn't mean I still don't get advice though. Even now, because I don't have educators with me, I use the senior CCRNs to sort of convey my thinking and see what they think. A lot of the time, they'll go, yep, nah, you're spot on, because I just need to trust my gut a little more. But sometimes they'll tell me, oh, no, you could probably put them a category lower because this, or you could actually put them a category higher because red flags, this. I've got a question here. How do I overcome my own doubts when challenged with a difficult triage? And a perfect example of this actually happened to me a few days ago, where I had a man come in. He was here for ultrasound results, and he was admitted like the day before for hypertensive crisis. He come in with a blood pressure of like 240 or something like that, and it was like unreadable at home, and he's never been to a GP before and stuff like that. So he got an ultrasound, came back. So I did his blood pressure and it was 214 on something or other. And he had taken the medication that was given to him the day before with no effect. So his category went from category 4, waiting for ultrasound results, to category 3, severe hypertension. And he was asymptomatic at the time. He had no headache, no vision disturbances, nothing like that. So I asked the CCRN, she goes, no, Cat 3 is okay if he's asymptomatic of this hypertension. So I went through, asked him if he was short of breath, asked him vision disturbance, headache, anything like that. He said, no. And then I asked him, do you have chest pain? And he goes, oh, got a bit of epigastric pain. And I went, oh. Like, it was the very last question I asked. And because he said yes, with the whole sort of history of it, couldn't really rule out a cardiac cause. So I gave him a Cat 2. And, I didn't think anything of it. And then one of the consultants came up and told me he should have been a Cat 3 because hypertension is a Cat 3. And I went, even though he's got epigastric pain? And they go, oh, it's probably nothing. So yeah, could have been a Cat 3. And I asked one of the CCRNs, she goes, oh, the way you've sort of framed it, Cat 3 would be appropriate, but it doesn't really matter if you've done a Cat 2. They'll just probably get seen quicker. And I'm like, and she goes, you shouldn't worry about it at all. It happens. Better be safe than sorry. And I was like, oh, okay. I'll take the feedback on, and I'll think about that next time this sort of happens to me again. And then maybe an hour. Oh, not an hour. Maybe 20 minutes later, the doctor went in and he looked like he was asleep on the chairs. He was pale, he was diaphoretic, he was incontinent. And he looked like he was sorry, I forgot to mention, we had given him more antihypertensives in the meantime. And we pulled him through, and he had further episodes of loss of consciousness, hypotension, bradycardia, and they were thinking it was a cardiac cause. And I was like, yes, my gut feeling, my gut instinct when hearing about this hypertension and this sort of epigastric pain that has only been there for a few hours, my gut feeling was correct. So I took away from that my gut is a valuable resource. When I just feel something isn't right, that is justification enough to up triage someone. And I've been told that actually, I won't mention that. So basically, what I've learned over these last 5, 6, 7 days that I've been allocated to triage is that I should continue to use my resources. So the triage guide, my senior CCRNs, my gut. Just really don't feel pressured to rush triages. I know they say that triages need to be done in 2 minutes, but it's okay for me to take an extra 30 to 60 seconds to reread what I've written, to recontemplate the story that has been given to me, the numbers that I'm seeing, and the physical appearance of the patient to really choose the right category. And so I said I was going to mention it and I didn't. Re-triage is also something I can do if I feel the triage I gave previously wasn't sufficient enough and the patient has deteriorated in front of my eyes, to say I gave that man a Cat 3 and he hadn't been seen yet, which he was about to be seen, but he hadn't been seen yet. We gave the antihypertensive and he had this episode. I could push him up from a 3 to a 2 for loss of conscious episode and hypotension. But yeah, I just need to sort of, and this has been an ongoing theme since I started nursing, and it's still something I struggle with to this day. But I just got to trust in myself, trust in my abilities to be able to use my critical thinking and choose the right category for these patients. It was something that I struggled with during my grad year, something I struggled with during TSP, something I even struggled with in postgrad going into resus. I know more than my brain leads me to believe. And I should really just start trusting myself to be able to use this knowledge that I've gained in an appropriate manner. And yeah, I reckon that's it for triage, to be honest. I have actually enjoyed the sort of break it gives from the everyday mundane sort of 1-to-3, 1-to-1 ratio. I don't have to do any high reads. I don't have to do any in-depth assessments. I just do a sort of cursory assessment. And I get to sit down all day, which is nice sometimes. You just, I don't know, there's been a few shifts where I sit at the triage window and I just do not get up because I have no time to. I think there was one shift I spent 8 hours at the triage window and I got up 3 times. Once was to go on afternoon tea break. Second time was to go on dinner. And the third time was to go do some full ward tests. And we were so busy that when I came back to do the send off the urine, I didn't actually have time to send off the urine until like 10 p.m. It just sat there next to my computer because I just didn't get up. And that's actually another tip that I've been told from my educators, that if I need a minute, if you need a minute, just take the minute. Just ask them to hold on, just got to do something first and come back. There's nothing wrong unless there's someone like that looks really sick, do them first. But for the most part, people that walk in can afford to wait that extra minute. Some can't, and that's okay, but majority can. So they were like, if you need the minute to go just have a sip of water or do something that you've been meaning to do, like get some pain relief for somebody, do a full ward test, send off the urine. Sometimes bloods and ECGs is a little too much to do, but just those simple tasks, just do them. It's not like you're there twiddling your thumbs. People will understand that that we're giving care. Yeah. So this wraps up this episode of my show Chronicles of a Learner RN. I certainly have learnt a lot, and I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.